CIHR, a brainchild of Stephen Matthews and Michael Meany. 6 years ago, some of us got a phone call to say, we have to go and do something about stress during pregnancy. And we actually became the clinical site. And we have now recruited into that study 250 pregnant women, where some of the kids are now 48 months old. We just got 2 grants to continue up to age 9. So we have 150 women who have scored on the adversity. They're stressed, anxious, and depressed. And we have 100 women who are controls. And what we are doing is we're looking at nutrition, at depression, anxiety, at alcohol and drug abuse. We're looking at all the environmental factors that you can imagine. We do that during pregnancy twice, and we do that immediately postpartum, and then at 3, 6 months, and then every 6 months on, probably until we all die. But in the meantime, we are actually looking at the maternal endocrine state. We look at the neural development, the psychoneural development of the children, adaptations and vulnerability. We look at cognition and emotional well-being of these kids. We do epigenetics with cord blood. We do genetics on both moms and babies. We have a data bank that is unbelievable. I only have 3 slides with data from one of my PhDs, Alison Shea, who piggybacked on the study and did a few little snippets in a subpopulation of a total of 70-some women, looking at the impact of depression on neuroendocrine and neurophysiological parameters. And remember, I said cortisol is very disappointing. This is the cortisol awakening response in these pregnant women. You see, this is our control group. This is a group of depressed moms, and this is a small group of depressed moms who were on antidepressants. There was a trend that we probably dreamed or fantasized, a trend that those depressed women who were on antidepressants were closer to the controls than to the moms who were just depressed. The more exciting stuff was that we actually did 24-hour Holter monitoring. We did HRV to actually look at the autonomic nervous system, which is another measure of stress reactivity and responsiveness. And in this case, we did have a statistical result which was significant. The higher the value here of the SDNN, which is a measure of the HRV response, the better the reserves are of you as a person to respond to a stressor, okay? The depressed group that was not treated with medication but was only exposed to all kinds of psychotherapy and support had a much lower capacity to respond to stress, whereas the women that were on antidepressants were not different from the controls, telling you that there is probably something that happens with antidepressants that are correcting that physiological difficulty. We also looked at the infants of the same moms, and again you see this time it's the reverse because it's not the SDD that you're looking at, but you're actually looking at the ratio between the LF and the HF, which is a measure of the HRV, and you see that the babies born to moms who were on antidepressants, this is at 3 months of age for those infants, are the same as the controls. This is the first time that anybody has shown that there is a transgenerational effect of HRV between depressed moms and their babies. This is just summarizing in words what I just said, and I'll skip that because I want to move to breastfeeding for a minute because I'm running out of time fast. And talk about what else you can do postpartum in terms of prevention, because I think that that is something where the future in terms of community-based interventions might go. One of our impressions over the years was that a lot of women who come and already had a postpartum episode in the past would tell you, what killed me the last time was sleep deprivation. Now, most women in the room, and maybe some husbands of women who were pregnant, will know that starting around the last trimester of a pregnancy, you're not very comfortable. You toss and turn. You run at night to the bathroom. You don't sleep so well. You're more anxious, and on and on and on. You're a little bit sleep deprived. Okay? You come to the hospital at 2 o'clock in the morning, and it takes 48 hours until this bastard is finally born. Okay? And you're totally sleep deprived, okay? What does the new system do? The new system brings the bundle of joy, lays the bundle of joy on your breasts, and says, now you look after that baby for the next 20 years, starting now, okay? She wants to sleep. But we don't have rooming out anymore. We have only rooming in, okay? So there is no choice. So we said, why don't we try and say to the system, these moms are jet-lagged, okay? They just landed from Australia. In order for the HPA axis to resynchronize, you need 5 days and 5 nights minimum, okay? Why don't we give it to them? We were able to convince the Ministry of Health in Ontario, okay, that these women can stay in hospital up to 5 nights where everybody else was kicked out after 60 hours, okay, that they can have a private room for medical reasons with no extra cost to them, that they will have rooming out, which means that they feed the baby between 10 and 11, the nurse takes the baby out, the bundle of joy is being brought back at 6 o'clock in the morning. They get a benzodiazepine if they need one when they go to bed, okay? And we visit them, our team visits them, usually on day 3, okay? With this, we were able to reduce the recurrence of a postpartum episode. If you look at the books, it will say if you had a previous episode, your chances of having another episode in unipolars. In bipolars, it's 1 in 2, but in unipolars, these are all unipolars. In unipolars, it's 1 in 4. We were able to reduce it with this intervention to 1 in 8, 1 in 10. It doesn't reduce it altogether, okay? But we don't know. Is this the loving, tender care that we provide because we screen them in advance? We explain to everybody your biggest enemy is sleep deprivation. We preach to the partner that when she goes home, she has to continue this prevention of sleep deprivation for at least 12 weeks and on and on and on. But the data look very nice, okay? So we did the Edinburgh postnatal depression scale on this population, and you can see that those who went through the intervention, there was a huge drop in the prevalence of the high scores, EPDS. And if you just took the women that really had the high score above 20 to begin with at baseline, then it's even more obvious that the majority of these women had a lower score postpartum. We've now implemented that in 5 hospitals around us, okay? And we're now having an OMHF grant to actually do a placebo-controlled trial, which means that some women will go into an arm which is called treatment as usual, and at random other women will actually benefit from that protocol, and we have already 100 women in that trial in now. But sometimes you have to prescribe a medication, and anybody who tells you that they have a drug that does not go into the breast milk, they don't know what they're talking about. Luckily, concentrations vary. Infants' absorption rates vary. The younger babies actually don't absorb much at all, and we cannot even detect it in the infant serum. And what you may not know is that we are the only discipline that is actually interested in the topic, okay? Psychiatry is in the forefront at looking at what happens with antidepressants and breastfeeding, okay? No other medical discipline has been interested in that, okay? So we have, although we only have like close to 700 pairs, dyads of moms and babies where this was monitored, plasma levels in the mom, levels in the breast milk, and levels in the baby, this is probably the best database that exists, and it's actually very reassuring. I belong to the generation where you were not giving anything during pregnancy, and you definitely were not giving anything for a breastfeeding mom, or you had to tell her you cannot breastfeed. And this was devastating. You have to think of a postpartum depressed mom who already thinks that she's not a good enough mother, okay? The last thing you want to tell her is, you can't breastfeed. Okay, let's move to perimenopause. I stole this slide from Donna Stewart. They're not hot flashes, they're power surges, and she would attest to that. So, again, I'm really old, okay? But we were still learning Benedict, okay? Okay? And Benedict said that menopause is a narcissistic mortification, it's an organic decline, it's partial death, okay? This is Deutsch, Helene Deutsch. And Benedict said, women have a biologic need for pregnancy and motherhood. The loss of reproductive function leads to desexualization. 1976, Parley in New York said, it sometimes seems as if the only thing worse than being subjected to the raging hormonal influences of the female cycle is to have those influences subside. She was a feminist.